I'm Susan Sterrett. I'm the director of the School of Public Policy and a professor in the school. And I'd like to welcome you to the School of Public Policy's 6th annual Judith Shinogle Health Policy Research Award Lecture. The family of Dr. Judith Shinogle established the Memorial Fellowship in her memory to support doctoral students committed to health policy research. Dr. Shinogle had a distinguished and productive career as a health policy analyst and research scientist. At the time of her death, she was a senior research scientist with the Maryland Institute of Policy Analysis and Research here at UMBC, and an adjunct faculty member in our School of Public Policy. So we really are so honored to be able to celebrate her life and memory. We're thrilled to present this award tonight to Jennifer Walsh. She is the 6th student in the School of Public Policy to receive the Shinogle Memorial Fellowship. Past recipients include Stephen Johnston, Michael Abrams, Allison Mitchell, Cheryl Camillo, and Jennifer Smith. Each year, it's an honor to present this award to members of our public policy doctoral program who are contributing outstanding research in the health policy field. It's also a pleasure to hear from them about their research and the policy research and advancements they are making. I think this is a wonderful way to honor Dr. Judith Shinogle's legacy, and we're really grateful to her family and friends for making this possible. Thank you for joining us tonight. We're so grateful to our donors who continue to make these lectures possible. Jennifer Walsh follows a long line of accomplished students who have done so much important research due in large part to the leadership of Dr. Nancy Miller and her fine mentorship. She is a leader in health policy research, and so we're grateful for the strong cohort that we have in honoring Dr. Shinogle. Now I'm going to turn our program over to Dr. Miller, who will introduce Jennifer Walsh, and Dr. Miller is Jennifer Walsh's dissertation advisor. So thank you and welcome.
Thank you. I also would like to welcome you and express my appreciation for coming out for this lecture. And I'd also like to express my sincere appreciation to the family of Judy for establishing this fellowship in her memory, which has supported so much wonderful research reflective of the work that Judy did. So it's now my pleasure to introduce Dr. Mary L. Cohen, who's the sister of Dr. Judy Shinogle. We're pleased that Dr. Cohen and her husband could join us for this lecture coming in from the University of Iowa, where she's an associate professor and area head of music education. Dr. Cohen researches music making and well-being with respect to prison contexts, writing and songwriting, and collaborative communities. Dr. Cohen has led the Oakdale Prison Community Choir since 2009 and is completing a book reflective of this work. And the book is entitled Silence Voices, Music Making in U.S. Prisons. Dr. Cohen has presented her research in 10 countries. She's been a commissioner for the Community Music Activity Commission of the International Society of Music Education, and she recently co-chaired the 2018 Community Music Activity. Dr. Cohen received her PhD from the University of Kansas. So please join me in welcoming Dr. Mary Cohen to provide a reflection on her sister, Judy.
Thank you. How's everyone doing today? I'm curious how many people that are here knew my sister Judy. Just if you've met her in person, so we kind of get a feel for how many people knew Judy. So not the large amount. So I'm here on behalf of my family to give you a little bit of information about my sister and also to show you some images. I put together a few images from all sorts of walks of our life. So let me get this started. And it'll just, I think, continue as I tell you a little bit about Judy. So on behalf of my family and Judy's partner and friend, Jim McCarthy, who's back here in the back, we all love Judy. We love her a lot. And it's a grateful opportunity to celebrate her inspirational spirit, her sense of joy, her curiosity to learn, and a big congratulations to Jennifer for receiving the award this year, Jennifer Walsh. So I am the youngest of 6 children in my family. As you see the slides, anytime you see a dog, this is Brunhilde. Judy had 2 dogs, both German short-haired pointers, Brunhilde and Siegfried, and Judy would bring Bruni into her office, and I think that was a big new thing here in the My Part Institute. So the family goes, there are 6 children. I'm the youngest of 6. That's Judy with my mother, Louise. And the oldest sibling is actually 16 years older than me. And the years apart were 1 year apart, 1 year apart, 1 year apart, 5 years apart, 5 years apart, there's Judy, and then 5 years apart, there's me. So Judy was really my sibling growing up. And a lot of the things that I did in life were really inspired by Judy. And back in 2012, when Judy, I used the phrase, she graduated to the next realm, unexpectedly, Matt and I came to DC to help clean out her home. And I found this notebook. Judy really loved having fun. And in it, there was this sheet of the things that it was called Goals 30-Day Challenge. She had, I don't know if she does these beautiful things reflecting on her goals. And in the 30-day challenge, there were 3 things that Judy specifically said she wanted to work on that really relate to the things that I'm interested in my own life. They were knowledge, family, and health. So I'm going to just briefly share with you how Judy really influenced me in so many different ways. When it comes to family, Judy, I got really excited about what Judy did. She influenced me to start taking piano lessons, actually. I do want to tell a quick little story about this image, because Judy finished her master's degree at Harvard. And I got to travel with my mom and my father to celebrate her graduate degree, and Judy and I really love ice cream. So they had a dairy festival, and they had this thing called a scooper bowl, where you got to get a cup and go through all these different vendors and try out all their ice cream. And Judy and I decided, first we were just going to eat the ice cream, enjoy it. Then we decided we'd try ice cream from every vendor we could try and just see what it was like. And we ended up, taking a bite and throwing out the cup because we couldn't eat that much. And then we decided, oh, we'll go to the Cheers bar after that. So that was kind of an interesting afternoon. So Judy, and this is a fun picture when Judy and I and Matt, my family took a cruise to celebrate my parents' 50th anniversary in August of 2001. And we like doing these really crazy pictures. So Matt and I did a funny one where we were kind of fighting each other. And the woman that was the photographer said, oh, look, there's my sister with her husband. They're the spies on board. And so then we decided to take another crazy one at that picture. So I mentioned the siblings. My oldest sister is the woman on the top left as you look, and my brother Bob. There's Judy and my sister Jane on the bottom right, and then I'm the one with the kind of reddish purple shirt. This is an image of Judy with my sister Linda, my mother Jane, and my mother's mother. Her name was Kunigunda Van Amen. And we used to grow up visiting her, and she would make cinnamon rolls, and we would play at her home. It was a lot of fun. And then one time we had a big family reunion. We called it the Blue Shirt Family Reunion because everybody from our family had blue shirts. So in this image, you can see from the top left, my husband, Matt, my brother Bob, his wife Sarah, my sister Linda, and one of her partners. Next to her is my brother-in-law Alan, his child who's now an adult. This is kind of an older image. On the far right, Jane, my sister Judy, Linda, there's Sarah again, and I'm at the bottom left, and my father, who 2 years ago graduated to the next realm. And then my mother, who's still alive in Wichita, Kansas, and then nephews Michael, Charlie, and Ben. So there's the full Shinogle family, and here we are celebrating at the cruise, I believe. And there's our wedding, Matt and I. Kind of a very funny image, especially with Michael, so there at the bottom left corner. Oh, lovely. And then here's a fun image where my family learned to do the little happy hula. That's Judy and my mother. And there is Judy with our dog. Before I was born, that's the dog Happy that we used to dress up with my father's old raggy clothes. Everybody had a lot of fun with that. And then here's a beautiful image of Judy because she really, really enjoyed having fun. In fact, the week after her accident, a lot of her friends had a celebration of Judy's life. And it said on one side, they made these bracelets that said, what would Judy do? And the answer was find the joy. She was always having fun. If things got crazy, she'd just say, let's just go to the baseball game and have fun. So that year, I decided this was when Judy died. It was the first time in my life I'd ever had anyone close to me die, and I hadn't experienced what that means to live with someone, especially someone that was my role model. And I started taking piano lessons because Judy did. I started teaching group fitness, and I earned my PhD because Judy was a direct influence for me. So that next year, I reflected on the idea of what does it mean to find the joy when you're dealing with grief. And so I composed a song that's called Find the Joy that talks about that process. The words are, how do you find the joy when brick walls block your path? How do you find the joy when you're living through the aftermath? And the whole song reflected on how do you find the joy? And I was teaching it to the choir I lead in Iowa. It's made up of men that are incarcerated and women and men that come and sing with them. And on the walk out of the prison, Kevin Coomer, an outside volunteer who'd been with the choir since we started in 2009, said, Mary, I don't think you ever actually have to go out to find the joy. It's actually always within us. We need to pause and feel it. So I changed after that conversation the end of the song that says, instead of how do we go out and find the joy, at the very end of the song it says we pause and feel the joy. So that song is on our choir website, Oakdale Community Choir. We have a section of original works where that song is available using the Creative Commons license. So I'll just conclude by sharing in the idea that I feel like when someone that's been close to us in our life does graduate to the next realm, we still have a pretty deep opportunity to make connections. And I feel like on a regular basis, I check in with Judy and I reflect on advice and in what ways can she help me just reflect on what's important in a decision or things that I should pay attention to. And one of the key things that I think is very important to reflect on as we think about people that are important to us, that are alive now or that have graduated to the next realm, is how can we increase our capacity for caring and caring about the people that we are around, caring about the people that are in our lives that we maybe don't have a direct connection with. And the hardest one is caring for those that we don't have any connection with. And I know I'm in the DC area now, but I would even go as far as to say is caring about people that have a different political view than care. And I just have really enjoyed the opportunity to delve deeper into my own spiritual life and who I am through my relationship with Judy in my life, how she's influenced me to do the things that I really love, and now to continue to develop this sense of care through all of the research that I do and the people I interact with. And big congratulations to Jennifer. A couple more brief images. I was thinking that was my last one, but I've got Jim here with Judy. And the final one, I thought this was a cute one to end with because it's Judy and Mom. And the little picture that you see on the wall is one of the paintings that Judy did. She did a lot of art, and it's a picture of Christmas with Judy and my mother dressed with a Christmas gear. It's Santa. A very funny Santa that when you turn it on and it moves, it kind of wiggles around like it looks like it's drunk. So anyway, let us all play with finding the joy within our lives and increasing our capacity for care.
Great. Thank you, Mary, for this reflection on Judy. I'd like to say I didn't actually, myself, while I was here, when Judy was here, didn't have an opportunity to work with her except briefly in 2012. We were working together on a grant proposal with colleagues at Towson University, and the grant proposal was focused on children and youth with autism spectrum disorder. And it had two pieces, and the piece that I worked on is kind of the work that I do, which focuses on kind of why states do what they do in their Medicaid programs. And Judy would have had the lead on the evaluation of the Maryland program for children and youth with special health care needs. Judy passed away before it was funded, but it was funded in September of that year with funding from what is now the National Institute of Independent Living, Rehabilitation Independent Living, in what is now the Administration on Community Living as part of Health and Human Services. And research itself has concluded with kind of important findings related not only to adoption, but the fact that the Maryland program in particular was an extremely effective program for youth, particularly transition age youth with autism spectrum disorder, as they transitioned out of high school into their early adulthood. So I've always appreciated that. So it's now my pleasure to introduce Ms. Jennifer Walsh. As we all know, she's this year's recipient of the Judith Shinogle Award. Ms. Walsh is a doctoral student in the School of Public Policy, where she focuses on health policy. She's a disability support specialist at Towson University. In this position, Ms. Walsh promotes equal access to educational opportunities to students with disabilities. Prior to this position, Ms. Walsh promotes, prior to joining Towson University, Ms. Walsh was a licensed psychology associate with the Johns Hopkins Hospital Division of Medical Psychology. And as a psychology associate, Ms. Walsh performed neurocognitive evaluations. Ms. Walsh began her professional career as a discharge coordinator with the Center for Eating Disorders in Baltimore. She received an MS in clinical psychology from Loyola University, Maryland, and a BS in psychology from Stevenson University. It's been my privilege to work with Ms. Walsh as her advisor and instructor, and now the chair of her dissertation committee. I'd like to note that the external reviewers who selected Ms. Walsh for the Judith Shinogle Award found her to be a particularly strong candidate, due in part to her sharing of research interests related to prescription drugs with Judy. Ms. Walsh will be presenting on her dissertation research related to the opioid epidemic, so please join me in welcoming Ms. Walsh to the podium.
Hello, everyone. Thank you, everybody, for being here. Thank you to Dr. Miller, my mentor. She took on a big task when agreeing to be my mentor, and she's, living that every day, poor thing. I especially want to thank certainly the other members of public policy and the support I've received from that department. Thank you to Pam, to Sally, to Miriam. Thank you so much for getting this all together. And really, thank you so much to the family of Judith Shinogle. I just think what you've done by setting up this endowment is so fitting to her career, and it's nice that we all get to come together every year and get to know her. I know a lot of people didn't raise their hands. I unfortunately didn't either. My husband did raise his hand. He did know her. I knew her through him, but we get to know her through this, and I just think it's an amazing tribute to her legacy that you're doing this. So let me get my presentation pulled up. Hold on. Okay. All right. So to walk you through where we're going, I'll start by telling you how I got interested in this topic. From there, I'll move into telling you exactly what naloxone is. Next, I want to talk to you a little bit about how we got here with opioids. moving into what the current epidemic looks like, including some demographic information about who this affects. And then I want to talk specifically about overdose education and naloxone distribution programs, of which I did a full systematic review that I'll mention briefly. And then I want to talk about Maryland in specific and how I plan on contributing to this field through my research proposal, and kind of bring it all together with a discussion of just kind of what still intrigues me about all this. So my personal interest, as Nancy mentioned, I have a background in psychology from Stevenson University and then Loyola University. And for about 8 years, I worked at Johns Hopkins Hospital, where I was doing neuropsychological evaluations largely on elderly patients. And what we were seeing is that some of the cognitive problems that they were having could possibly be attributed to the fact that they're seeing multiple doctors and getting multiple prescriptions, and that there's some interactions between the drugs that could be causing those cognitive problems. So I came into this program with the interest of, is there a better way that we could be managing all these prescriptions for patients that don't necessarily even follow with a primary care physician? They're just seeing doctor, 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 and having all these medicines. Is there a better way that we can manage it? So I started learning through my research about prescription drug monitoring programs, thinking those might be the answer to this mismanagement of drugs. And what I was finding was that wasn't their purpose. Their purpose really was kind of at the abuse and of prescription drugs such as opioids. So it was really not targeted towards what I was thinking, but it was really targeted towards this epidemic that was really developing at the time I entered the program. So when I first started doing research, I was finding some stuff, and now I mean, I can just go on, so as I'm doing my research, just so many tangents. There's just so much out there about the opioid epidemic. It's hard to stay relevant, but it's still such an intriguing topic. And you just talk with people, and people have different passions related to that. And a lot of people, they're passionate about it because they know somebody that's affected, or they're affected, or they lost somebody. So I want to move into this next image, which is a very powerful image. I actually debated on whether to include it or not, but the New Yorker released a piece called Faces of an Epidemic. So what you see here is an actual photo where they've lost somebody to a heroin overdose. And why I included this is I want us to keep in mind, as we progress through all these slides and all these research, is at the heart of this problem, people are dying, and these are people's family members. So I don't want to forget them. I don't want to just talk about them. I want to really remember that this is why we do the research that we're doing, because we want to stop this. So I started to think about naloxone. So naloxone is a drug, if you didn't know this, that can reverse an overdose immediately. An overdose itself starts with a suppression of the central respiratory system. From there, the person loses consciousness, there's a cessation of breathing, and ultimately they die of cardiac arrest. So the naloxone, and one of the brand names of it is Narcan, and so you often may hear Narcan more often. Naloxone can move the opioid drug away from the receptors, so that stops the overdose process. So it's an antagonist medication. The window of opportunity to intervene and stop an overdose is 1 to 3 hours. So if found in time, people really do have a chance with this drug. It was initially approved by the FDA in 1971, and at that time it was an injection. So training was necessary, and it was used most by first responders, so first in the emergency rooms, and then it started to be paramedics, and eventually there was moves to have it on firefighters and police officers as well. My historian husband also tells me that 1971 was the same year that Nixon revealed his war on drugs. The two actually aren't related, but it is an interesting kind of piece of history. And just remember, drugs have been around for a while. The most recent iteration of naloxone was actually 2015, where there was a nasal administration. So prior to this, there was actually an off-label use that developed. They learned that by attaching an atomizer, I don't know if I'm saying that right, to the syringe, that instead of doing it through the muscle, you could do it through the nose. So if it's easier to administer, we kind of have the question of, could we save more lives and get to people faster by training regular people like you and I to administer naloxone? So I want to talk about how we got here. So 1914 was a Harrison Narcotics Tax Act, which had a specific section about opioids. So that just goes to show you, again, this problem has been around a long time. More recently, thinking of prescriptions now, the period of 1980s, we can reflect back to being a period of opiophobia. So there was really a problem where doctors were not addressing appropriately the level of pain that their patients were having. So patient advocacy groups started to lobby state medical boards to change this. And what it resulted was doctors were encouraged to be liberal and proactive in their treating of pain. So that meant they weren't going to face any disciplinary action. There was no maximum on how much they could prescribe or how frequently they could prescribe. In fact, in 1999, JCAHO introduced pain as the 5th vital sign. So along with your temperature and your heart rate, they were now going to start asking patients about their pain level. So think about now some of the forms you might fill out when you're going to a new doctor, and on there's like a rating scale of like 1 to 10, or smiley face to frowny face, and just different ways of asking, like, what's your current pain level? So doctors are now treating pain, great. Pharmaceutical companies respond, of course, with very aggressive marketing campaigns. They also respond by releasing more formularies, including some extended release. So OxyContin is the brand, one of the brands of oxycodone by Purdue Pharma. So they were approved in 1995, and by 1996 there was 316,000 prescriptions, and Purdue Pharma was receiving $44 million in sales. So moving into the 2000s, physicians, great, are now very active in treating their patients' pain. And that next one, so I just said what it was in 1996, and now we're up to 2002, 6 years. Look how much more money they're making. So there's a lot of drugs out there now. Along with that, the NIH starts to do a lot of research on pain management. Congress declares 2001 to 2010 the decade of pain control research. And at the state level, there was Intractable Pain Treatment Acts, which was like criminal immunity for the physicians. So I just mentioned Congress, and I just wanted to also mention, politically speaking, when we talk about the opioid epidemic and even some of what I was talking about with pain control, this has really remained a bipartisan issue. This isn't something that Republicans and Democrats are feuding over. In fact, there was just, like a week ago, Trump signed a new act to fight the opioid epidemic, which I'll talk about in a little bit. But you see how it passed. It passed in the Senate with a vote of 98-1 and 393-8 in the House. So you can see that there is generally bipartisan support on this topic, which is good news. So back to those prescribing patterns. Just to show you a few things. So from 97 to 2007, The average opioid milligram per person rate went up 402%. Sales of oxycodone went up 839%. The prescriptions went up 1,259%, keeping in mind that population growth at this time was only 16%. So really going up, but we're treating pain, so maybe that's good. By 2012, there's 259 million opioid prescriptions, so enough for every American adult to have one bottle in their medicine cabinet for an entire month. There's a lot out there. So we're treating pain, and that would be fine, but people start dying and overdosing, and that's not fine. So in 20 years, the amount of overdoses attributed to prescription painkillers tripled. Currently, 46 people every day die from prescription opioids. If you look at this graph, you can see from 1999 to 2013, the green line is the sales. So we said, yes, our sales of prescription drugs are rising, but along with that, the deaths are rising too. And that signals a problem. One study showed that there's a 0.68, so a pretty strong correlation between opioid sales and overdoses. So we start to consider that now we maybe have a new problem of prescription drug abuse. So all patients will, when taking prescription opioids, will endure tolerance and dependence. So tolerance is the idea that in order to achieve the same level of pain control, you need more and more, so a higher dose. And dependence is that you need to continue taking opioids to avoid the withdrawal symptoms. And we know that the withdrawal symptoms are significant and considerable and need to be carefully managed. Nearly 12 million teens and adults actually report that they take prescription drugs to get high. They actually report that. Imagine the people that aren't saying yes to that question, but actually do. And 81% of drugs that are taken for non-medical use, so taken for abuse, have come from a legitimate prescription from a physician. So I like to pause here and talk about legitimacy, because I've gone to a lot of community, open mic kind of events, and just in talking with people, and there's always that argument. I'm saying argument negatively, but people always are quick to point out that they need their drug. And they're facing a lot of scrutiny from people now that this is such a hot topic, that it's almost kind of like it's not okay to have a legitimate prescription. And so that's not what we're necessarily going for either. So I do like to point out that there is a legitimacy to prescription painkillers. There is a need for them, and there is a place for them in medicine, but there is a problem also with abuse. So really, I think this was another word I can't say, but iatrogenic problem. So I think this is a problem that was created by medicine, in that they defined that there was not enough pain management, so pharmacies release a ton of medicine. And what happened is prescription opioids became the de facto treatment for pain. That's what patients knew to ask for, and that's what doctors knew to recommend. And what really wasn't researched as much was other options. So were there non-narcotic pain options that could have been considered? Was there things like physical therapy or occupational therapy or acupuncture or massage that could help people's pain in a non-narcotic way? So it's like a different form of dependency. Patients believe that they need prescriptions to control pain because that's what they were told. That's what they came to believe. So, and pain itself is very subjective. We all know this. I mean, how they have the smiley face and the happy face and the frowny face, and they have the 1 to 10, but how do you really actually quantify pain? At best, you might have somebody that had the same surgical procedure as you, got their wisdom teeth out, had a baby, and can relate to that experience, but how do we know that the pain that person's feeling is the same or worse or better than, it's so subjective. And there's really a fine line. Again, all patients are going to experience tolerance and dependency, and addicts will experience the same as well. So there's a really fine line between the normal experience of prescription pain and addiction. So as prescription drug abuse becomes a problem, there's pressure on physicians, think of the prescription drug monitoring programs, to really rein back in this problem. So they start to scrutinize their patients and not offering refills and making them sign contracts, various things to just put a layer of control in. And the unintended consequences, these patients are kind of the ones left suffering. They were told that this is how we treat pain, and this is how we've been treating your pain, and this is how we're not treating your pain this way anymore. We need to find something else. So there is a new set of victims here, and I don't want them to be lost in all this. And I definitely always struggle with that aspect of legitimacy. So, but what we do know is that for many, it did turn into an addiction. So things like prescription, all these policies that were aimed at reining back in the prescription drug abuse had some people turning towards the black market, where heroin is both cheaper and easier to obtain. They're not going through the scrutiny that their doctor was giving them. If they just know somebody, they can probably get heroin pretty easily. This graphic here is very interesting to me because it mentions that heroin is part of a larger substance abuse problem. So people who are using heroin are 2 times as likely to use alcohol, 3 times as likely to use marijuana, okay? 15 times more likely to use cocaine, and 40 times more likely to use painkillers. So, and really, people aren't necessarily turning straight from painkillers to heroin or back and forth. They're alternating between based on what they can get at the time to maintain their addiction or pain control or what have you. So 79.5% of heroin users reported that they started with prescription painkillers. 2 studies actually showed, so that's pretty significant. In 2010 to 2016, the heroin-related deaths increased by 5 times. Very substantial increase in that. This graphic here, I get a lot of my graphics from the CDC, and they're great. So that kind of goes through what we've been talking about. So from the 1990s, we've had 351,000 people from 99 to 2016 die. It started in the 90s with the prescriptions. In 2010, we see the increase in heroin, and now most recently, there's an increase in the synthetic opioids. So that is things like fentanyl and tramadol. So fentanyl and tramadol are used in medicine, but what we're seeing is they're being illegally made and synthetically made, and they're on the black market. So this is a timeline. You see that first wave, the light purple, of the prescription opioids rising fairly steadily. In 2010 is when you see that first time that it dips. But also in 2010 is where you see heroin take off, a very sharp increase. And not too long before fentanyl or the synthetic opioids in 2013 has an even sharper increase and actually surpasses heroin and prescription drugs. Anybody know who this is? Yes. And if we actually remember, I mean, we can actually think of lots of celebrities that have had a death attributed to an opioid. He was specifically to fentanyl. So fentanyl itself is a synthetic opioid pain reliever. It's approved for treating severe pain, so think end-of-life care, advanced cancer. They use it in surgery. It's 50 to 100 times more potent than morphine. It's often mixed with heroin or cocaine to increase its euphoric effect, but here's the kicker. A lot of times people they're not aware that what they're purchasing has been laced with fentanyl because it's the black market. Nobody's really doing product control. They don't know what they're buying. So that's a lot of the deaths that we're seeing is sometimes the people are just unaware. Very similar graph. And you see those three again, but why I include this one is that it includes all opioids together. So you see how that just increases. And even as we get into the 2013, that line just keeps going. And you can tell that's largely driven by the synthetic opioids, but certainly a combination of all three. And throughout these years, there's been a ton of public policy interventions. Everybody's been trying to fight this. This isn't like we're just now realizing the problem and looking back. All along, we've been trying to figure out what we can do to fix this. And it's not working. So the current epidemic is currently 115 Americans die every day from an opioid overdose. So I have to pretty much update my slides every year. And so last year, this was 91. Now it's 115. It's not getting better. And you've seen that second stat. So currently 46 people die every day from prescription opioids. So still fentanyl and heroin are driving the majority of that number. But remember, still a chunk is from legal drugs. Thinking of who this affects, I want everybody to really focus on everyone. Now, I can certainly give you some statistics that with the age bracket, most affected in heroin is the ages 25 to 34. With prescription opioids, it's more middle age, 45 to 54. It affects males greater than females. In terms of race, it's majority white. Really rural and urban, so obviously urban. Baltimore City has the most numbers within Maryland, but they also have the highest population. So if you look at the per capita rate, it's really affecting rural and urban areas about the same. But amongst all these groups, and any group you can name, the numbers are increasing. So everybody's being affected by this. And I want people to take away that it's happening in your neighborhood. It may be happening in your family. And honestly, I want you to believe that it could happen to you. Because if you believe that and stop thinking of this as like somebody else's problem, I think we can be careful and I think we can look out for one another and so I just want everybody to just, believe that to some degree and just be careful. So it affected this little girl. This is a picture of somebody practicing giving naloxone on her stuffed lamb. But this was a girl that has a parent who's a drug abuser, and she was trained to use naloxone. So back to that original question, can we save more lives by training everyday people to administer naloxone? So we have an easier administration, and we also have identified some barriers, such as not getting to a person in time, and also that for some people with addiction, they're afraid of activating the emergency personnel system just out of fear. So if we train everyday people, can we save more lives? So these programs kind of developed out of the harm reduction program model. So the idea of harm reduction is that we accept addiction as part of our society, and we're just trying to reduce the harms around it. Hoping that it eventually leads to recovery and improvement, but for the time being, kind of accepting where we're at and implementing interventions to just reduce the harms. So with this, these programs offer training that either people will walk away from the training with a prescription to obtain naloxone or actually walking away with an actual naloxone kit. So these programs were developed actually first with drug abusers in mind, figuring they would be the most likely to witness an overdose because often people don't use in isolation. But it expanded quickly to include family members and like security personnel at like college campuses or just anywhere where they might be seeing overdoses. They wanted to have naloxone on hand. So I conducted a systematic review, which is a very detailed, systematic literature review. And I was really trying to see what the effectiveness of these programs were and if it had any effect on the mortality rate and the overall overdose rate. So I started by searching 8 databases and coming up with a total of 1,363 articles by searching the words Narcan or naloxone, overdose, fentanyl or heroin or opioids to kind of include all that. And I wanted to look from 2010 to recent, so I did this last year, so 2017 it was. And I wanted peer-reviewed journals, English only, US only. So I went through the levels of the systematic process, removing the duplicates, got down to 561. Just reviewing the titles, I was able to get down to 266. Reading the abstracts, I actually was able to get down to 54. Reading full text, I went down to 15. And after just doing the careful data extraction, I ended up with 12 articles that I was able to use in my systematic review. So a good breadth of literature there. And you see here the different authors. The years range again from 2010 to 2017. The amount of kits that were distributed through their programs range from, there was a small one, 37, to a very large one, 39,000. And then they had them, they asked the participants to report if they used the kit that they were given and the amount of overdoses that were reversed. Now they didn't have to, and of course that's a problem with the studies in a way, but the amount that were reported range from 3 to 658, and I calculated the percentages there. But don't pay, with a percentage, it may be that the 39,000 people, they got a kit, but maybe they didn't experience an overdose of somebody. So that's okay too. But what this shows is that if you distribute kits, people will use them. More details about the programs. So the actual name of the program themselves, where they're located, the administration method. So some were nasal, some were both, and some were still the injection. And then just some participant characteristics. So a lot were family members, a lot were substance abusers themselves, and et cetera. So what did I learn through my systematic review? With this literature, I was able to find that they established feasibility across several settings, so family support groups, primary care clinics, emergency departments, drug treatment facilities. One of the larger studies was the VHA, so established feasibility amongst different populations too. So people that are at high risk of either experiencing or witnessing an overdose, substance users themselves, family members, etc. I did, in my systematic review, include an analysis of risk of bias and internal validity and kind of got an understanding of what the limitations were. One of which was that there were few geographical regions represented. So 4 were from California, 5 were from Massachusetts, and then there was 1 each from Ohio, Maryland, and then the VHA one was a national. And only 1 study included that next step, so was analysis of the overdose and mortality rates. So that's what had me thinking about what I could do. And I do plan on focusing on Maryland. So Maryland itself, in 2015, issued a statewide order that anyone could go through the overdose response program, receive training, and then with that prescription get dispensed naloxone. March 1st, 2017, Governor Hogan, who actually has a family member who died in this crisis, he declared a state of emergency regarding the opioid epidemic, and we were the first state to do so. In fact, he did that ahead of when Trump ordered a national state of emergency. In May of 2017, Governor Hogan signed the Hope and Treatment Act of 2017, and from that, on June 1st, there's a new statewide standing order allowing pharmacists in Maryland to dispense naloxone to anyone. You don't need to go through the training. Now, there's still value in the training because a lot of times they're giving the education as well, but they're also giving the kits directly to people. So they're able to walk away with an actual kit like that they can use that day. So there's still a lot of value, even though you don't need it to obtain it, there's still a lot of value in those programs. In fact, from 2014 to 2018, through Maryland's overdose response program, just over 100,000 people were trained. They dispensed over 127,000 kits of naloxone. Now, mind you, that number's higher because they ask, again, that people report when they use it. So 2,930 cases were reported. When they report it, they can obtain a new one. So that's why that number is higher. And that's good, that people are using it and getting a new one. So that's roughly 2%, thinking back to the systematic review and kind of where that fell. This is looking at drug overdose rates. So the national average is 19.8 per 100,000 standard population. The green area is lower than that average. The light blue is about average. And then dark blue is above average. So where is Maryland? We are above average. So the problem is significant in Maryland. This is looking from 2007 to 2016. So unlike the other graphs that I was showing before where we started at 1999, so we don't see that increase in the red of the prescription opioids. It actually looks kind of steady, but it's high, it's not low. Heroin actually has some dips and valleys. 2010 to 2011 remains steady, but from 2011 on up, you see that increase like we saw in the national averages. And then fentanyl is kind of non-existent a little bit up until 2013, like we said, and then you see that a really drastic increase. That's how we're doing in Maryland. So for my proposal that I'm working on, I do want to do a local study looking at Maryland's implementation of the overdose response program. And the fashion I wanted to use is the interrupted time series. So using those two dates of the standing order of the access to naloxone, it kind of creates a natural experiment in a way. And so that ends up being my independent variable. And the dependent variables I would like to look at are those overdose rates, so fatal and non-fatal, just any occurrence of an overdose, the mortality rates, and I'd like to find some way of looking at the recovery rate. So to see, is anybody getting better? That's going to be harder to find. Some ideas are looking at the number of treatment admissions or maybe how many facilities open up in an area as a way of like operationalizing that variable, or to be determined. But I just really want to see, because I know that right now, if somebody overdosed in this room, that a dose of naloxone will reverse it. I know it saves individual lives, but what we don't know is it working on that bigger scale? Is it actually having an effect on death and overdose rates, and are people getting better? That's what we really don't know. In fact, this is kind of the quarterly included on Maryland's BHA website. So that standing order was in 2015 and then 2017. So here we are in 2018, and the number is increasing still. Now that's driven mostly by fentanyl. So heroin, the numbers of deaths attributed to heroin are actually down a little bit, and prescription opioids is down a little bit, but fentanyl is way up. So fentanyl is driving that overall number. And something I just want to point out, if you add up those first numbers, they're going to be higher than 1185. Again, people aren't necessarily using one exclusively. when people die, they're likely going to have heroin and fentanyl, or prescription opioids and heroin in their system. So I hope this has everybody thinking, and it certainly has me thinking. So if I do my analysis and everything looks good and the numbers are going down, then that's great, it's working. But what if it doesn't work? And that's what I'm afraid of, that this isn't working. It's saving individual lives. Like right now I can save your life, but maybe it's not working on that bigger scale. So what could be at play here? So one idea is the idea of the Peltzman effect. So with motor vehicle accidents, they were initially afraid that introducing seatbelts would increase risky driving. And the Peltzman effect is really that the two cancel each other out. So yes, people will drive riskier, but seatbelts themselves will save lives. So what you're left with is the Peltzman effect. So with drugs, it's very possible, and anecdotally you hear this, that drug users may engage in riskier behaviors because the fear of overdosing is removed. So I have friends that are firefighters that'll tell you they're coming out the same day and administering naloxone to the same person. They're not afraid of dying. Also, they might just use more because they're less afraid, or they just might alter how frequently they use it, or they might feel more free to mix it with those other drugs. So there is some degree of engaging in riskier behavior. So that possibly could be driving a lack of effect if I see it. In fact, because I'm just not moving fast enough with my research, somebody already kind of published, actually did not publish this, but came out with a paper discussing this, called The Moral Hazard of Life-Saving Innovations, Naloxone Access, Opioid Abuse, and Crime. So these two individuals were economists, so it's a working paper, which is a little bit more typical for the field. It wasn't peer-reviewed. A very controversial paper, because we want the message to be that naloxone is good and that more people should have it. So a paper like this that says it's not working is controversial. But they didn't see an increase in emergency room visits, actually theft. With mortality, they saw no decrease, and in the Midwest, they saw a 14% increase in mortality. So they were interviewed about their paper, and the quote I included is that their takeaway is that they don't want to restrict access to naloxone. It's that we need to make sure we are doing other things that address the root cause of this crisis. And that's about what I feel about it too. I don't envision a day where we're ever going to make any attempts to get rid of it. I'm not trying to take away its power that it can save lives, but I'm just trying to make sure we're doing it, we're including it in the right mix of other stuff. Another consideration, and actually Lena Wen from Baltimore City talks a lot about this, is that the price of the drug has gone up. So remember, the pharmacy companies made a lot of money by introducing prescription opioids. Now they're making some money by introducing its antidote. So one study showed that since 2006, all formulations of naloxone increased in price except for Narcan, so that brand name actually stayed stable in its price. Some reasons were just, supply and demand. There's an increased demand because of the epidemic, or perhaps a drug shortage at times, or limited competition. So Narcan has remained steady in its pricing, which is about $63 a dose. They most of the time sell it 2 doses for $125. They will sell to government agencies and community organizations, so those programs that distribute the naloxone kits, for $37.50. Now these prices, if you compare it to a life, it's nothing. But out of pocket, for many families, this is quite prohibitive. Baltimore City pays about $35.40 a dose for naloxone. It used to be $21.77, so the price is going up. If they're trying to put it with all the first responders and distribute it to community members, this is a good chunk of the budget, especially if they need more and more and more of it. And at times they have run out in Baltimore City. So when a person they're revived from their overdose, a lot of times they're not waking up grateful for their new lease at life. These are people that are suffering from severe addiction, and oftentimes they're refusing to go to the emergency room, or they're refusing to seek out further treatment, or sometimes they want treatment and there's nothing available to them. It's either too expensive or there's no beds open. So just because we save their life doesn't mean we have the ability to take it to the next step. And so we have to keep in mind naloxone is just one part of a multifaceted solution. So back to that bill that Trump just signed last week, which by the way was a 1-year anniversary of when it was declared a national emergency. His plan doesn't actually include anything specific about naloxone. But again, we're not getting rid of anything. But some additional things that he did include was just expanding treatment, and so giving people greater access to recovery. He is including some funds to research non-addictive opioid alternatives. And he's trying to address the high prescribing rates that still exist and enhancing prescription drug monitoring programs. There are some law enforcement mechanisms built into it, and just allowing communities to access federal resources and grants to local communities to specifically fight fentanyl. And they're finding that a lot of fentanyl is shipped from other countries, so they're trying to develop a way that you can test packages at the post office to see if that's what's coming in. And just bringing it all together, this is where I'm at in public policy. Is I believe that naloxone is an important life-saving intervention that should be a part, but not the only part, of a multifaceted plan. And I just hope that my contribution to the research is just pointing out what role it plays, and then maybe what we learn from that might point to some other things that we might not have considered, especially when we're falling under the realm of harm reduction. So I think there's a lot to be considered that's slightly outside of the box and really just falling under the idea of allowing people to use, but use more safely. Maybe that is worth considering, but honestly, I just want to it's a big problem, and there's a lot of people talking about it, and I just want the one little piece to make a difference. So, what did I do? Okay. And that's it. So I would love to talk with people about it. I included my email address down there if you have any ideas, if I made you think of anything. I talk a lot with people, personally and researchy. I also put up 2 more resources down there. One is the Daniel Torch Foundation. So Toni Torch is a mom in Harford County. Her son died. And again, this is one of those faces of the epidemic. She really wants Harford County families to know that her son is, she just wants people to know that this is a problem in her community. It was in her family. She talks with a lot of people that says, that's a city problem, or they must have drove down to the city to get that. And she wants people to know, no, it's happening here in our nice neighborhoods. And so the money that she raises, actually, she distributes kits to, she's one of those community organizations that actually trains the individuals and distributes naloxone directly to them. And then another, the Rally Prescription Drug Abuse Leadership Initiative of Maryland is just providing the education, and they also just try to bring together the different entities into kind of community open format type situations. So they bring the different politicians and they include family members and just try to bring people together in like open conversation about it. So keep on, everyone. Thank you so much.
Thank you, Jennifer. We have time for a few questions, if anyone has a question for Jennifer.
Jennifer, as you probably are aware, there's other things going on in Maryland
Yeah.
at the same time that may also impinge upon things like observed abuse rates and observed overdose death rates. I know there is at least one study that was, I don't think it was specifically to Maryland, but was across a number of different states suggesting, for example, that that marijuana availability tended to be negatively related to overdose death rates. So I'm wondering whether you've thought about including some of that in Maryland, particularly given that Maryland has also finally gotten started with its medical marijuana program, and it's sort of slowly rolling out.
Right, so that could be one of those answers that falls under harm reduction. So that if we allow people to use a different drug and to use it legally, might they be less interested? And marijuana does have some benefit in terms of, you said medically, with pain relief and other things that it could help with certain conditions. So if we allow that, could that help with the opioid crisis? And maybe. I think probably we can look to some other states that adopted medical marijuana earlier to see if that's worthy of consideration in Maryland. But I feel like this is all about unintended consequences. So we wanted to control pain, so we put a bunch of painkillers out into the community, and now we have a prescription drug problem. So we want to control the opioid epidemic, so we might allow everybody to use marijuana, and what other problems might that create? So that's where I think we have to carefully take lessons from other areas, and unfortunately time will tell, and sometimes we don't have time to wait to see. We have to act and hope. So very interesting, and maybe, I don't know. Anyone else?
So you had a statistic towards the beginning of the presentation about the percentage of the misused opioids coming from a legitimate prescription. Was that 81?
Was that 79.5 or 80? Yeah, I think it was 81%. Yeah.
Has there been any type of research done on the deactivation bags that exist for opioids, and if there's an effectiveness there?
So funny you mentioned that. When I went to a community organization meeting with Raleigh, they gave me one of those bags. And I actually totally meant to reach out to them and see if I could get one for everybody. But so there's these bags that you put the drugs in and add water, and it and certainly drug take-back days, people need to know what to do with their leftover prescriptions other than hanging on to it. So I don't know. They're new to me, and I don't know of any research, but I think they're a great idea. When I said I want everybody to be careful, one of the things that's my soapbox issue is that you really should mention to no one that you attained, if you had surgery. I know when you have dental surgery, I think my husband went through dental surgery, and my friends asked me, did he get the good stuff? Why do you want to know that? And for a lot of people, it doesn't mean anything, but obviously it was my hot topic issue. And I think everybody should be very careful with their drugs. I had one that I was keeping in a medicine cabinet, and I went back to throw it away, and I realized that somebody had put Walmart's version of Gas X in there. So somebody stole, I don't know who, and I don't know when, but somebody that came in my house actually took my one leftover prescription drug from a dental surgery. And when I say that to people, I see some people nodding, something like that's happened to you too. You'd like to think it might have been some stranger that just so happened to be in your house for doing work. Yeah, but it could have been a friend or a family member. So really try to mention to nobody that you have them, and what you have, keep locked in a safe. Not just the pain, but there's other controlled substances like ADHD medication and benzodiazepines and stuff. Hi.
Well, I'm Stephanie Hassan with the Bureau of Behavioral Health in Baltimore County. Thank you. Very interested in seeing how this progresses. Thank you for looking at this. We do a lot of naloxone training. To your question about the bags, I just have to do a commercial. I hope
Please,
you don't mind.
please, I
In
love
Baltimore
this.
County, every day is Drug Take Back Day, and we have drug boxes located outside of every police precinct. Folks can go, they're there, take the drugs that you aren't using, get rid of them. They have the box. Nobody is looking at what you're putting in there. But you can do that every day.
Yes, thank
And
you
we also
so much.
have the bags for
The safe
for people
disposal.
who are homebound that maybe can't get to that. So
I
thank you for the
appreciate that.
commercial.
Thank you.
I was going to share a story that when I was in high school and I got my wisdom tooth surgery, the day that I came back, a student actually asked me if I had any, opioids left. And immediately that day went home and flushed everything down the toilet because that had never even crossed my mind. I was in high school, junior high school. You don't think about those things. But I wanted to ask about pain as a fifth vital sign. So right now I'm a student nurse on a surgical unit, and I've worked on many units, and kind of the standard of care is asking about pain every 4 hours. And then in the PCAM, which is basically like a patient satisfaction survey when they get discharged, one of the main questions is, was your pain treated? So what can we do about that? Do we ask about pain less? Do we not put it in the patient satisfaction survey? Like, I always have a difficult time like reconciling knowing that we have an opioid epidemic, but yet pain is asked so much in the hospital and on the patient satisfaction surveys.
Yeah, and it's it's that fine line. And no, I don't think we should stop addressing people's pain. And I think those initiatives are great, but I think it needs to also include alternatives. So when you go home, here are your alternatives for treating pain. Maybe encouraging patients, you can try ibuprofen. If that doesn't work, then try the narcotics. And then just offering the education along with it. Again, back in the 90s, people were it became such a de facto treatment that people just really believed that this was the be-all and end-all for pain relief. So there's alternatives they need to know about, and they also need to know about the potential for addiction. That wasn't included back then. And I don't know if it's included now, but I think along with, there's some initiatives that say every time you give out a prescription for opioids, you should also distribute naloxone along with it. There is some value there too, but at the very least, provide education that an overdose, an addiction problem, these are possibilities with this drug. So keep on doing the good work you are with the patients, and I definitely think we still need to address pain. I don't want to move away from that, but just what else too? Go ahead.
I'm not in the medical field, so I don't know if this exists, but is there talk of developing substances that are kind of like co-acting drugs that you can take with an opioid that would like block the receptors the way Narcan does, so that way it addresses the actual physical pain, but it doesn't, or somehow block, I know that that's what's causing the addiction, but that diminishes the addictive effects of it while still letting it have like the actual neurological impact.
I think I've seen, there are less addictive forms, and some of them are used to help move patients off of the addiction, like buprenorphine and Suboxone. It's a good question. Nancy, does anything come to mind?
Someone else may know. I did some reading this summer. I didn't really see anything like that, but it's a good question.
I don't know if I'm sure that adding another drug to your cocktail is not necessarily a long-term policy solution, but in terms of people who want to take opioids, who need it for the chronic pain and want to take them responsibly and then get carried away with,
Well,
as
that's
opposed
an
to this
interesting
other
point.
high-seeking demographic.
That's an interesting point, is that the original intent of these drugs were never meant to be long-term. People aren't meant to live and raise families while on them, or drive, or go to work, or they're not meant for long-term. So we need to really research if somebody needs to be on something long-term for some condition that's not going to be fixed through surgery or whatever, what's the safest alternative? And move away from, well, oxycodone takes away the pain, so let's just keep you with that. So it's very interesting.
You talked about wanting to study recovery as well.
Yes.
And you also shared just your general feeling that in a lot of cases when people are taking naloxone, that it's almost like an empowering for them to continue taking it in the future, because it saves them and they feel in some way immune, I guess, to death or something. And I'm wondering how would you structure looking at recovery? Would that be qualitative, or how would you even begin to frame that?
I'm not sure.
Okay.
And there's kind of like what I want to do and what I think I'll be able to do. I would like to say that something's working, that people are getting better, or they're not, and identify that as a problem in which we can improve upon. But just because somebody's admitted to treatment doesn't necessarily mean that they're recovery. And then if people report recovery, that is again subjective. And so I'm not sure. It's something I'd like to be able to do, and I don't know. I'd love to, if anybody had some thoughts on it, I'd love to hear it. Go ahead.
Is there any data out there to cover like kind of the road, I guess, through addiction to an opioid overdose? Because it sounds like this is preventing like really severe cases in terms of overdose, but it doesn't explain how or like how long or how much usage of opioids it takes for patients to get there. So is there any data on that?
Yeah, I mean, as much as we know about addiction, we don't know. And some people say that there is a gene for addiction and that you may have it or you may not. And certainly in some families, that seems to make sense, that there are several people that have suffered from addiction and other families where there's none. But you know, they haven't found a gene. So, so what makes some people be able to take it and get off of a prescription easily, and what has other people struggling with an addiction later? No, we don't know. And that is another interesting area of research, and you may get a lot of anecdotal stuff there, but if we knew that, that would be a good piece of the puzzle, you know, if we could just figure out why people get addicted and then some don't. Yes?
Potential serious side effects of naloxone?
No.
Is that included in training?
That's a great question. It is included in training, and really it's a safe alternative. A lot of the symptoms, again, I have firefighter friends, and they'll tell you that when it's administered, the person almost immediately vomits. But from there, the symptoms or the signs that you see are more consistent with just withdrawing from the opioid. So there's nothing specific, and you can use it again and again. It doesn't lose its effectiveness within a person. There's no addiction potential to that itself. And it's a relatively safe drug. So yeah, we want to keep it around.
One more question?
So we're actually all from the University of Maryland School of Nursing, and opioid epidemic is such a big part of our curriculum.
Good.
And so we have read so many peer-reviewed articles for different assignments, and I just wanted to add that I don't know the answer to your question, how a person gets addicted, but it's actually really hard for a person, after a procedure, if you just follow the regimen that your doctor gives you, with frequent assessment, like what you said, reassessment of, does this patient still need such a strong painkiller, or can this person be, I guess, can this person start taking Tylenol and things like that for mild pain? It's actually really hard for someone to be addicted if you just follow the prescription and the regimen that your physician gives you. And another thing is that, for naloxone administration, one thing you should consider is your own personal safety, because when you administer it, the person is brought back, but it's not in a pleasurable way. They're not going to thank you. They're not going to feel wow, it's good to be alive. They're going to be violent. They're going to hate you because they're probably there's not side effects, but I think that you're coming off of such a high that it's like, why did you just do that to me? Why did you, you know? So it's really like
Yeah.
personal safety for yourself is like a big thing for you to consider as well, to keep that in mind.
And thank you. I soft pedaled around that, but again, knowing people that administer that on a daily basis frequently mention that they're afraid and that people get pretty combative. So again, you would like to think people wake up and it's like, thank you so much, you saved my life. But unfortunately, that's not exactly what's happening. But that is part of their addiction. It's not them, it's part of their addiction. So thank you, everyone.
Thank you. We do have, as part of the lecture and award, a plaque for Jennifer. And Jennifer also received a fellowship to support her in her studies.
Thank you.
And I did want to say in closing, I want to again thank everyone. Thank particularly the Shinogle family for setting up the award and for the many individuals who continue to provide funding for the award so that we can continue to recognize students. And a final note, just to show that people do move forward, both last year's recipient, Jennifer Smith, who's here with the Hilltop Institute, who is doing research related to the comparative effectiveness of asthma treatments, and Cheryl Camillo, who received it the previous year looking at several issues related to Medicaid, will both be defending their dissertations later this month and graduating in December. So we